Some of you may have been in the very excellent skeletal dysplasia session earlier on, so this is not at this level. This is an idiot's guide to skeletal dysplasias, or in fact metabolic bone diseases. They're uncommon, but not quite so uncommon if you actually bother to look for them. They can be frightening, but slightly less so if you know a little bit about what you're talking about and that you try to understand them. After all, skeletal dysplasias, metabolic bone conditions, underlie a lot of what our practice is. A skeletal dysplasia is simply a disorder of osteochondral development. They're often inherited conditions, and in order to discuss them, you maybe need to learn a new language or two. We have to know about height, and we have to know the importance of your child's height relative to the parental height and relative to their parental height corrected for the influence of their sex hormones. You have to think about short stature, whether it's short limbs and short trunks, proportionate or disproportionate. You want to start looking at your child and trying to work out where the primary abnormality is clinically. Is it in the upper arm, the middle of the arm, or the distal arm? You want to think about the anatomy of what you're talking about. So which part of the bone is affected, at least primarily? Is it the epiphysis, the metaphysis, the diaphysis, or the spondylobit, i.e. the back? And you can't forget this sort of radiolucent physis bit as well. Because depending on which bits are involved, it gives you a clue as to what problems your patient might experience. If the epiphysis is involved, then joint problems are likely to be a problem. The spine, of course, will lead to instability and kyphoscoliosis. If it's the metaphysis that's primarily involved, you'll be short with deformity, and you may have secondary joint problems to the deformity without necessarily there being a primary problem with the epiphysis or the articular cartilage. So when you're faced with one of these, you're not going to panic. You're going to start thinking, how can I assess or analyze this? So what is this? Well, it's a dysplasia, it's a generalized problem, and the primary abnormality seems to be in the metaphyses. So this is a metaphyseal problem, a metaphyseal dysplasia. What about this? It's a dysplasia. The main problem is probably in the epiphyses. They look a little bit abnormal. And if you look at the knees, then you automatically realize that this is multiple epiphyseal dysplasia. This is very simplistic way of thinking about it, but it gets you in the right mode and gets you thinking. So what's this? This is a dysplasia. Definitely the epiphyses are involved. But if you look at it a little bit, the metaphyses are quite broad as well. And then there's too many words on this slide, so let's get rid of the physeal bit there and call this an epimetaphyseal dysplasia. And of course, if the proximal femoral epiphysis is involved, then you're likely to have a secondary or primary, perhaps, acetabular dysplasia as well. And when you've looked at all of that, then you have to ask yourself, is there some abnormality of the vertebral body as well? And if so, then you add the word spondylo. So you now have a spondylo-epimetaphyseal dysplasia. Just a string of words, but at least it begins to help explain what you think the problems are with the child in front of you. But then, of course, this simplistic system will let you down, because here you have a case where the main problem seems to be in the acetabulum. There is some spinal involvement. There's definitely involvement of the distal upper limb, and it's called an acromesomelic dysplasia, so that doesn't fit. But at least the building blocks that I've just told you about will give you something to just hang your hat on when you're thinking about these conditions. But if a pure anatomical classification system is not enough, what else are we learning about these days? Well, we know that the skeletal dysplasias are on the whole inherited. So perhaps we should be thinking about a genetic classification to go with the anatomical classification. We've learned a lot in the last decade or so about the genetic basis of both metabolic and skeletal dysplasias. We know about the chromosomes, we know about the short arm and the long arm. We're beginning to understand where the abnormalities lie. So that on the short arm, P, of chromosome 11, you can get problems with growth and a hemihypertrophy type problem. On the chromosome 17, Q, the long arm, that's where a lot of our collagen genes are found. So genetic-based classification has begun to explain more about the genotype relating to the phenotype. It helps you know your enemy. It helps you predict what else may be going wrong or going on, and it helps you understand the pathology and maybe guides your treatment because you understand the basis of what you're dealing with. It helps us understand whether our bones are straight or bent and what's likely to happen to them in the future. It helps us know whether the bones are soft or not. Will they bend or break? And it helps tell us whether the bone is actually bone or whether there's more fibrous and cartilaginous elements within the bone than you would like. So we're getting a much better understanding of the pathology that underlies the musculoskeletal problems. In simple terms, with achondroplasia, for example, we know there is a very consistent, very specific genetic defect which is the cause of all the problems with achondroplasia. And we may well soon be finding a genetic cure for the problem. Similarly, with multiple epiphyseal dysplasia, we know that the phenotype that goes with the genotype is very wide, but we do begin to know where the underlying problem is, and we understand that there is more than one genetic hiccup, if you like, that can present a picture which is similar to a multiple epiphyseal dysplasia. And we know where the defect lies for many other skeletal conditions which are overlapping. So these are metabolic bone diseases that represent a skeletal dysplasia, but may be due more to a hormonal or a specific collagen problem. So we now know in osteogenesis, as we'll be hearing later, where the primary abnormalities are. We know now where the hyperphosphatemic rickets abnormality is, and we're beginning to know how to treat that. And again, with the MPS conditions, we find out that MPS 1, the defect is on the short arm of chromosome 4, very close to the defect that causes achondroplasia. So these conditions, which we thought were very different, may be in fact more similar than we imagine. So if you're faced with a generalized problem with your bones and your joints, you should think skeletal dysplasia, but you should think and widen your net to also think metabolic bone disease. The overlap between the two conditions radiographically and clinically can be really quite broad, and it's up to you to use your clinical acumen to start deciding whether this is simply a skeletal dysplasia or whether it's a metabolic bone disease which requires you to think outside your orthopedic box and involves some help as well. Thank you.